All right. So a very good evening, everyone. So in this particular section, mainly I'll be discussing about the arrhythmias. So we are supposed to discuss both the atrial arrhythmias and as well as the ventricular arrhythmias. But mainly I'll try to concentrate first in the atrial arrhythmias. So in which I'll be discussing in detail about the atrial fibrillation. Yeah. So yes, very good evening, Dr. Deepal. So this particular section, mainly I'll be concentrating on the topic of the atrial fibrillation. And in the next section or in the subsequent sections, I'll be discussing about the ventricular arrhythmias, that is VT and as well as VF, right? So if you take this, the atrial arrhythmias, what exactly is it? It is a cardiac arrhythmia with rapid and irregular atrial electrical activation, right? It is the one with rapid, irregular atrial electrical activation. And this atrial electrical activation that will lead to loss of the organized contraction of the atria, right? Loss of organized contraction of the atria, and subsequently that will progress to the disorganized contraction of the ventricle as well. Now, if you take the prevalence of the atrial fibrillation, it is very common as the age of the individual increases. Now, more than 95% of the atrial fibrillation, it is very common over the age group of 60 years, right? Those individuals over the age group of 60 years, the risk of the atrial fibrillation is very high, right? And those individuals who are of age 40 years, in them, the chances of the atrial fibrillation is around 25%. So basically, as the age of the individual increases, the chances of the atrial fibrillation also increases, right? Next. Then what are the etiologies that will be causing the atrial fibrillation? So we have this particular mnemonic, and this mnemonic is the atrial fib. And out of all these various etiologies, the most common cause for the atrial fibrillation will be hypertension. Now, out of that, apart from that, what does this A stands for? That is the alcohol abuse. T is your thyroid disorders, and that too, which thyroid disorders? That is hyperthyroidism will contribute to your atrial fibrillation. And this hyperthyroidism will not only contribute to atrial fibrillation, it is also associated with the ventricular tachycardia and as well as the ventricular fibrillation as well. And the word R stands for rheumatic heart disease. And as such, rheumatic heart disease mainly involving the mitral valve, causing mitral stenosis, that is associated with the left atrial enlargement that can progress to the development of atrial fibrillation, right? Then the word I is the ischemic heart disease can predispose to the development of the atrial fibrillation. And the next, like A, we have that is atrial myxoma. So whenever there is atrial myxoma, there will be left atrial dilatation or there will be left atrial hypertrophy. So left atrial dilatation or left atrial hypertrophy is associated with the development of the atrial arrhythmia, that is atrial fibrillation. And the word L, right? The word L, it stands for lung disorders. So how these lung disorders will progress to the development of the atrial fibrillation is by the development of the cor pulmonale. And the word, okay, F actually, it is the pheochromocytoma, where there is excessive release of the catecholamines, and that can progress to the development of the atrial arrhythmias and as well as the ventricular arrhythmias as well. The word I is idiopathic and the word B is your blood pressure. So this is the mnemonic for the etiologies causing the atrial fibrillation. Then how do you classify the atrial fibrillation is? Now, when there is first episode, we call it as only just first episode. But when will you call it as recurrent atrial fibrillation? We use the word recurrent atrial fibrillation when the number of episodes are more than 2. Then we call it as recurrent atrial fibrillation. And when do you call it as paroxysmal atrial fibrillation? When the atrial fibrillation, if it is present for less than 7 days, right? If it is present for less than 7 days, and if it is self-terminating, then we call it as the paroxysmal atrial fibrillation. And when do you call it as persistent? If it is present for more than 7 days, we call it as the persistent atrial fibrillation. And when do you call it as long-standing persistent atrial fibrillation? Long-standing persistent atrial fibrillation is that when the duration of the atrial fibrillation, if it is more than 1 year, we call it as the long-standing persistent atrial fibrillation. Then when do you call it as the permanent atrial fibrillation? Permanent atrial fibrillation is that where the rhythm control is not pursued. Okay, so here the rhythm control is not successful. Rhythm control is not successful. That is called as the permanent atrial fibrillation, right? Now, out of which you take this paroxysmal atrial fibrillation. So paroxysmal atrial fibrillation, what did I tell you? The one which is self-terminating, and that too within 7 days. Now, you need to know what are the triggers for the development of this paroxysmal atrial fibrillation. The triggers for paroxysmal atrial fibrillation will be stress, then excessive consumption of the alcohol or alcohol binge, next infections. So these are the triggers for the paroxysmal atrial fibrillation. Whereas for persistent atrial fibrillation, as I have said you, this will be lasting for more than 7 days. And these patients with persistent atrial fibrillation, they require medical intervention for the reversal. And this medical intervention that includes cardioversion, right? That includes cardioversion that is required for termination. That is called persistent atrial fibrillation. Whereas long-standing atrial fibrillation, like what is that we have discussed? In case of, 1 minute. Right, so in case of the long-standing atrial fibrillation, I said you that this atrial fibrillation will be lasting for more than 1 year, and here rhythm control attempts are often unsuccessful, right? So rhythm control attempts, they are not successful in case of long-standing persistent atrial fibrillation. Then we have one more terminology called atrial fibrillation with fast ventricular rate. When do you call atrial fibrillation with fast ventricular rate is whenever there is high ventricular rate. Now, how much should be that high ventricular rate? That high ventricular rate, it should be more than 110 beats per minute. That is the point when we use the term atrial fibrillation with fast ventricular rate. And patients with fast ventricular rate, they have worsening hemodynamics. In the sense, they will be having hypotension, they will be having pulmonary edema causing increase in respiratory rate, there will be rapid fall in the saturation, and there is also increasing the risk of the heart failure, right? Increasing the risk of the heart failure. So that is AF with FVR. Then we have what is called AF with CVR, that is controlled ventricular rate. So here the ventricular rate is maintained within the normal limit. Okay, so here the ventricular rate is being maintained normal or near normal ventricular rate. Right, normal or near normal ventricular rate. And how much should be that ventricular rate? The ventricular rate, it should be less than 100 beats per minute. That is AF with controlled ventricular rate. So here there is reducing symptom burden, and there is also improvement in the cardiac function. Right, there is also improvement in the cardiac function. Okay, so this is the AF with controlled ventricular rate. Done. Then followed by that, this AF, that is the atrial fibrillation, it worsens the underlying cardiac disease. Whatever is the underlying cardiac disease which is being present, if there is overlapping atrial fibrillation on that cardiac disease will get worsened. Like AF will worsen the underlying cardiac disease by what is the mechanism? Because whenever there is atrial fibrillation, there will be increase in ventricular rate, that will increase the myocardial oxygen demand. And it will also promote the fibrosis of the underlying cardiac disease. And by increasing the ventricular rate, it will impair the cardiac output. And by increasing the ventricular rate, there is high risk of stroke and as well as the heart failure. Because once your atrial fibrillation occurs, there is chances of thrombus formation, and that will progress to thromboembolism. And there is also risk of the heart failure. Now, what are risk factors that are causing electrophysiological changes? risk factors causing electrophysiological changes. So electrophysiological changes are driven by the hypertension. Hypertension is one of the risk factor which will cause the electrophysiological changes. Next important risk factor is the obesity. The next important risk factor is the obstructive sleep apnea. Next, myocardial ischemia. Then aging of the person. Then excessive alcohol consumption. Right? So these are all the risk factors which are causing the electrophysiological changes within the myocardium that will predispose to the development of the atrial fibrillation. And whenever there is an atrial fibrillation development, there will be worsening of the cardiac disease by increasing the myocardial oxygen demand, by promoting the fibrosis, by impairing the cardiac output, and by increasing the risk of stroke and as well as the heart failure. Now, you take this pathophysiology. So basically, there is abnormality within the atria, or there is abnormality within the progression of the atrial fibrillation. So if you see the pathophysiology, multiple risk factors, they lead to electrophysiological changes, right? So number one, ectopic beats within the atria can cause atrial fibrillation. Atrial remodeling can cause the atrial fibrillation. Fibrosis of the atria can trigger the atrial fibrillation. Left atrial enlargement seen in patients with mitral stenosis can trigger the atrial fibrillation, right? And promoting the atrial fibrillation progression can trigger the atrial fibrillation. These are all the multiple risk factors that will lead to the electrophysiological changes. And not only that, it is ectopic beats, atrial remodeling and fibrosis and left atrial enlargement that will cause the atrial fibrillation. Now, what will be the clinical manifestations in patients with the atrial fibrillation? The primary symptom is the palpitations, right? Why is that? That is because of your irregular ventricular rate. So the cardiac output is reduced. So these patients, they will also have the fatigue, and there is also hemodynamic impact. Because of the hemodynamic impact, they will have the exercise intolerance, right? They will have exercise intolerance. Then because of the hemodynamic collapse or hemodynamic compromise, these patients can develop pulmonary edema, due to which these patients will also have dyspnea. And not only that, because of atrial fibrillation, there is increase in atrial rate. There will be stasis of the blood within the atria, resulting in the embolic risk. And this emboli will progress to the development of the stroke. And there is a terminology called tachycardia-induced cardiomyopathy. What is this tachycardia-induced cardiomyopathy? Because of tachycardia, there will be cardiovascular dysfunction. Right? So because of tachycardia, there will be cardiovascular dysfunction. Okay. So that is what is your tachycardia-induced cardiomyopathy. So this will be the clinical manifestations that you will have in patients with the atrial fibrillation. The primary symptom is palpitations, and that is due to irregular ventricular rate. Next, how do you work up these patients with atrial fibrillation? The important investigation is the ECG. What does this ECG show? ECG will show you that there is irregular rhythm, right? There will be irregular rhythm. Then followed by that, there is no P wave. Then followed by that, there is no P wave, right? And in the place of the P wave, there will be presence of the fibrillatory waves. In the presence of P wave, there will be presence of the fibrillatory waves, right? That is what is the ECG changes in AF. And yeah, yes, Ilham, good evening. Right. And what is the purpose of Holter monitoring? The purpose of Holter monitoring in patients with atrial fibrillation is mainly to diagnose the paroxysmal cases. Right? Mainly to diagnose paroxysmal atrial fibrillation, because paroxysmal atrial fibrillation will terminate spontaneously without requiring treatment. So to diagnose the paroxysmal cases, Holter monitoring is required. Then what is the purpose of doing echocardiography? Echocardiography is done mainly to determine the LA size and to determine the presence of thrombi within the left atria. And you need to do blood test to make up what is the underlying cause for atrial fibrillation, right? So thyroid stimulating hormone to rule out thyroid related disorders which may be causing atrial fibrillation. Brain natriuretic peptide, because atrial fibrillation can cause tachycardia induced cardiomyopathy which can cause increase in brain natriuretic peptide. And at the same time, renal function to be assessed because the anticoagulants or the antiplatelets which we will be giving in the treatment of atrial fibrillation, they require a very close monitoring of the renal function and alteration of the doses of that particular drugs. So this is the workup that you need to do in patients with the AF. Now, what are the complications which are anticipated in patients with AF? One important is stroke. That is because of thrombus and then embolization. Then heart failure. What could be the reason? That is due to tachycardia-induced cardiomyopathy. There can be development of the heart failure. Left atrial enlargement. Rheumatic heart disease causing mitral stenosis. Mitral stenosis will cause left atrial enlargement. That will predispose to the development of the atrial fibrillation. Then systemic embolism and as well as dementia. Why there will be dementia? If there is small emboli, if they are shivering into the cerebral parenchyma, that can cause the multiple infarcts that can predispose to the development of the dementia, right? Now, if you take the risk of stroke in patients with AF, the risk of stroke is nearly around 25%, right? AF causes 25% of the stroke. Now, to prevent the stroke, like what is the scoring system that we need to follow? That is CHA2 DS2 VAS scoring system. In this particular CHA2 DS2 VAS scoring system, this will predict the stroke risk, right? This will predict the stroke risk. Now, when is that you need to give anticoagulant? Now, if the score is more than or equal to 2 in men, then you need to give anticoagulant. You need to give anticoagulant if the score is more than or equal to 3 in females. If the score is more than or equal to 3 in case of females, that is when you need to give the anticoagulant. So this is about the stroke risk. This is about the stroke risk. Now, following this, let me discuss in detail about the treatment of the atrial fibrillation. Whatever we have discussed until now is the pathophysiology, clinical features, etiology, risk factors, complications. Let me discuss in detail about the treatment. So, first and foremost, in any case of arrhythmia, you need to know when to give emergency cardioversion, right? Emergency cardioversion should be given in any patient with arrhythmia if there is hemodynamic compromise. So, if there is hemodynamic compromise, then the emergency cardioversion should be given. Or if the individual, because of the arrhythmia, is progressing to the development of pulmonary edema, that is also the point when emergency cardioversion should be given. And if there is evidence of coronary ischemia, then also you need to do emergency cardioversion. So, hemodynamic compromise, pulmonary edema, and coronary ischemia in a case of AF, you need to do emergency cardioversion, right? So this cardioversion, it can be either electrical and as well as the chemical cardioversion. But whenever you are giving electrical cardioversion, what is that you need to give is, you need to give synchronized shock. And that synchronization is with the QRS complex. And this always should be done under sedation. This always should be done under sedation. But whenever you are giving this chemical cardioversion, this requires the anti-arrhythmic drugs. What are these anti-arrhythmic drugs that you give for chemical cardioversion? That is ibutylite. Right, that is ibutylite. But whenever you are giving this ibutylite, very important thing that you need to take care is this should be avoided in patients with QT prolongation. Okay, so this ibutylite should not be given in those patients with QT prolongation. Right, ibutylite should not be given in patients with QT prolongation. Very, very important point. Right now, so emergency cardioversion has to be done if the individual is having hemodynamic compromise. But if suppose, if the individual is the hemodynamically stable patient, what is that you need to do? If the individual is hemodynamically stable, please remember, you need to do rate control first. Right? You need to do rate control first. Followed by that, so just remember this, rate control, then anti-arrhythmic drug, then followed by that, sorry, the word A stands for anticoagulation, then followed by that the cardioversion, that is chemical cardioversion or the electrical cardioversion. That is in case of stable patient. Whereas in case of unstable patient, directly we do the cardioversion only. But in stable patient, rate control, then anticoagulation, then you need to consider for rhythm control. Okay. Now, if suppose, right, if the duration of the atrial fibrillation is like more than 48 hours, or if the duration of the atrial fibrillation is not known at all, in that patients, if you do cardioversion, that increases the thromboembolism risk. That increases the thromboembolism risk. So what is that you need to do in order to prevent the thromboembolism risk if the duration of the atrial fibrillation is more than 48 hours? You need to give anticoagulants. So anticoagulation should be given for at least 4 weeks. Right? Anticoagulation should be given for at least 4 weeks. Right? That is what you need to do if the duration of the atrial fibrillation is more than 48 hours. So the anticoagulation should be given for at least 4 weeks post cardioversion. Right, post cardioversion. Okay, so the point here is if the duration of the atrial fibrillation is more than 48 hours or if it is unknown, what is that I have said you that you need to give the anticoagulation. Now, so they require how long the anticoagulation? They will be requiring the anticoagulation, just 1 minute. Okay, so they will be requiring the anticoagulation for nearly around 3 to 4 weeks, right? 3 to 4 weeks, or it is like 3 weeks before cardioversion, right? 3 weeks before the cardioversion, right? Or the transesophageal echocardiography should be done mainly to exclude left atrial thrombus. I'm repeating what I have said. If the duration of the atrial fibrillation is more than 48 hours, or if the duration is not known, right? You need to give 4 weeks of anticoagulation post cardioversion, right? And you see the next one. If the duration of the atrial fibrillation is more than 48 hours or unknown duration, then you need to give anticoagulation for 3 weeks before cardioversion, or the transesophageal echocardiography should be done to exclude the left atrial thrombus. To exclude the left atrial thrombus. Okay. Now, how is that you need to evaluate the left atrial thrombus or left atrial appendage thrombus? So, you should evaluate left atrial appendage thrombus, that is by transesophageal echocardiography, or the cardiac CT has to be done. So, transesophageal echocardiography or cardiac CT is used to evaluate left atrial appendage thrombus. Now, this left atrial appendage thrombus evaluation should be done before cardioversion. Before cardioversion, right? So once the left atrial appendage thrombus is not there, then you can do this chemical cardioversion or electrical cardioversion, right? Then what is the long-term maintenance of the anticoagulation? So anticoagulation is continued in long term. That is based on the CHA2DS2 VAS scoring system, right? CHA2DS2 VAS scoring system. Based on this, the long-term anticoagulation is required. So anticoagulation is continued long-term based on CHA2DS2 VAS scoring system with stroke risk assessment guiding duration. So based on your CHA2DS2 VAS scoring system, we will be able to assess the risk of stroke, and that will decide the long-term maintenance of the anticoagulation. So that is about like what you need to do if the duration is more than 48 hours or if it is unknown duration, right? Now, so what did we discuss in case of the patients of atrial fibrillation who are hemodynamically stable? Rate control is what is required first. Now, how will you achieve acute rate control and how will you achieve the chronic rate control? So acute rate control, this aims to prolong the diastolic filling time, right? This aims to prolong the diastolic filling time and it improves the cardiac output, because whenever you give rate control, the ventricular rate is reduced. So thereby what will happen to your ventricular filling? Ventricular filling is increased and that will increase the cardiac output. So how is that you need to achieve this acute rate control? Acute rate control is achieved with beta blockers. Acute rate control is achieved with calcium channel blockers, or acute rate control is achieved with digoxin. The next important is the chronic rate control, right? So chronic rate control, it is focused on maintaining the symptoms. Okay, it is focused on maintaining the symptoms and preventing the tachycardia induced myopathy. That is the purpose of chronic rate control. Acute rate control, it is mainly to improve the cardiac output. Chronic rate control is to maintain the symptoms and prevent the tachycardia induced cardiomyopathy. And what is that you give? Same. Beta blockers, non-dihydropyridine calcium channel blockers, then digoxin. Right? Then digoxin. So these are the drugs that you need to give for the chronic rate control. Right? Then followed by that, we have some interventions that we do in the treatment of the atrial fibrillation. What are those interventions? That is the ablation and as well as the pace strategy. Ablation and pace strategy, this involves the AV node ablation. Right? This involves the AV node ablation. After the ablation, the pace strategy. AV node ablation with pacemaker implantation. Right? With pacemaker implantation. Now, why is that you are doing this pacemaker implantation? That is mainly to achieve rate control. Right? That is mainly to achieve rate control in refractory cases. Right? That is mainly to achieve rate control in refractory cases. So that is ablate and pace strategy. When will you do this ablation and pace strategy? In refractory cases not responding to medical management. Then coming to stroke prevention in the atrial fibrillation. Stroke prevention in atrial fibrillation, it relies on the anticoagulation, right? And whether to give anticoagulation or whether to give antiplatelet, it is completely decided by your CHA2DS2 VAS scoring system. Now, if you see the comparison of the anticoagulations, right? The anticoagulations that we have is warfarin, and the next important molecule is direct acting oral anticoagulant drugs. What are these DOACs? These direct acting oral anticoagulant drugs are the apixaban. Then we have the other molecule, that is dabigatran. Next we have the edoxaban. And the next important oral molecule is rivaroxaban. Okay, so these are the anticoagulations, right? When you compare these warfarin and as well as DOACs, the direct acting oral anticoagulant drugs, they have very few dietary restrictions, because whenever you are giving this warfarin, the individual has to avoid the leafy vegetables because they are very rich in vitamin K. But when the individual is taking direct oral anticoagulant drugs, dietary restriction is not required. And not only that, these direct acting oral anticoagulant drugs, they have very few drug interactions. Right? They also have very few drug interactions. Okay. So this is the comparison of the anticoagulation, right? Now, so here the intervention is ablate and pace strategy in refractory cases. Then what are the surgical interventions that we have in patients with AF? Surgical interventions that we have in patients with AF, that includes maze procedure. Right? That includes maze procedure. And the another important procedure is left atrial appendage occlusion. Right? Left atrial appendage occlusion. Okay. So this left atrial appendage occlusion using devices, what is the name of that particular device? That is the Watchman device. right? The name of the device is the Watchman device. Now, by using this Watchman device, that will reduce the stroke risk, because, right, this will reduce the stroke risk because this left atrial appendage device, that is Watchman device, once you are placing, there is no chance of thrombus formation now, or there is lesser chances of thrombus formation, because the most common site for thrombus formation in atrial fibrillation is left atrial appendage. And what is that you are doing? In the left atrial appendage, you are placing the Watchman device. So there is lesser chances of thrombus formation, and there will be lesser chances of the embolization, and there will be lesser chances of the occurrence of the stroke, right? Then followed by that, rhythm control. So if you take the rhythm control strategies include the anti-arrhythmic drugs, right? Anti-arrhythmic drugs. That is one point. And so what is that anti-arrhythmic drugs? The anti-arrhythmic drugs are the amiodarone that we give for rhythm control. And the next important molecule is the ibutyllite, right? Next important molecule is ibutyllite. And if the individual is refractory to these drugs, next is what? Catheter ablation, right? Catheter ablation or the electrical cardioversion should be done. So this catheter ablation or electrical cardioversion should be done mainly for the symptomatic patients, right? In asymptomatic patients, right, you don't require to do this catheter ablation or electrical cardioversion. Only for symptomatic patients, they require the catheter ablation or electrical cardioversion. Now, let me discuss about this catheter ablation as well as the electrical cardioversion. So, catheter and surgical ablation for maintaining the sinus rhythm. Catheter ablation is effective for recurrent, right? It is effective for recurrent symptomatic atrial fibrillation. Right, recurrent symptomatic atrial fibrillation, you need to do this catheter and surgical ablation for maintenance of the sinus rhythm, right? And this catheter ablation, right, that is having a very good outcome in patients with paroxysmal AF, right? In patients with paroxysmal AF, then compared to that of the persistent AF, right? Paroxysmal AF, the outcome is good then compared to that of the persistent AF. And another important procedure is the pulmonary vein isolation procedure. So this pulmonary vein isolation procedure, it is a cornerstone of the catheter ablation, right? It is the cornerstone of the catheter ablation, right? So in pulmonary vein isolation procedure, what is that you will be doing is you will be targeting the ectopic triggers, right? You will be targeting the ectopic triggers. Now, once you target these ectopic triggers, that will prevent the atrial fibrillation recurrence. That will prevent the atrial fibrillation recurrence. Okay. Then, even when you are doing this catheter ablation, there are certain complications, right? What are the complications associated with the catheter ablation? Number one, stroke. And the risk of stroke is nearly around 0.5 to 1%. And there can also be development of the cardiac tamponade. And the risk of development of the cardiac tamponade is nearly around 1%. And there can also be phrenic nerve paralysis, right? Phrenic nerve paralysis. And there can also be pulmonary vein stenosis, right? Pulmonary vein stenosis. And there can also be atrioesophageal fistula. Right? Atrioesophageal fistula. So this will be the complications of the atrial fibrillation. So this is about the treatment of atrial fibrillation. So in the treatment of atrial fibrillation, please remember, rate control is very, very important. Followed by that, the anticoagulation, followed by that rhythm control. But those individuals, this is like in case of hemodynamically stable patient. But in hemodynamically unstable patient, emergency cardioversion should be done. Either electrical cardioversion or chemical cardioversion. Electrical cardioversion, synchronized DC shock, 200 joules. Whereas chemical cardioversion, you require the ibutylite. But again, if the individual is having QT prolongation, you cannot give ibutylite. And very, very important part of the discussion of the AF is the trials, right? So there are totally 6 trials for the AF, and there is very, very high chance that the questions will be asked on the trials. Number one is the AFFIRM trial. What they have compared in case of the AFFIRM trial was, is the rate control important or rhythm control important in the atrial fibrillation, is what was done in the AFFIRM trial. And what this AFFIRM trial said is the rate control was non-inferior to the rhythm control, right? And rhythm control, it had more adverse effects with no survival benefit. So basically, like AFFIRM trial said, rate control is very much important than compared to that of the rhythm control in patients with the atrial fibrillation, right? Then next important is the race trial. And here also this said about the rate control versus the cardioversion. Cardioversion for what? That is for rhythm control, right? And what it said was the race trial, race rate control was as effective as rhythm control with fewer hospitalization and the adverse effects. That was about the race trial. And our next important trial was the East AFNET 4 trial. So this East AFNET 4 trial, what this has compared is, so early rhythm control versus the usual care. Early rhythm control versus the usual care. What it has showed is the early rhythm control reduced cardiovascular death, stroke, heart failure events compared to that of the usual care. So not giving the treatment for rhythm control will increase the cardiovascular death, will increase the stroke, will increase the heart failure. But giving the drugs for rhythm control is very, very important. That will reduce the cardiovascular death, that will reduce the stroke, and that will reduce the heart failure as well. The next important is the RELY trial. And RELY trial, it is basically the comparison of the anticoagulants. They have compared dabigatran versus the warfarin. And what said in this trial was the dabigatran, when you give 150 milligrams, was much more superior than compared to that of warfarin in reducing the stroke risk, right? And 110 milligrams had lower bleeding risk whenever you are giving 110 milligrams of dabigatran. It has lesser chances of bleeding risk. But what said was, by the RELY trial, dabigatran was superior than compared to that of the warfarin. Next was Aristotle trial. Aristotle trial has compared the apixaban versus the warfarin. What was said in the Aristotle trial when the comparison was done? What it said was apixaban was superior to warfarin for stroke prevention, and it had lower bleeding and mortality rate also. So that was about the Aristotle trial. Then the next was the Rocket AF trial. What this Rocket AF trial was done? So this was the comparison of rivaroxaban with the warfarin. And even this also said that rivaroxaban was non-inferior to warfarin for stroke prevention with similar bleeding risk but lower intracranial hemorrhage rate. So RELY trial, this dabigatran, warfarin, dabigatran was superior. Aristotle trial, apixaban, warfarin, apixaban was superior. Rocket AF trial, rivaroxaban and warfarin, rivaroxaban was superior. Okay, so this is about the trials in case of the atrial fibrillation. Now we will do some questions on the topic of the atrial fibrillation. Just give me 1 minute. Right. So this is the first question. We have a 72-year-old with hypertension and diabetes presenting with palpitations and as well as dizziness. And ECG shows the irregular rhythm without distinct P waves. What is the most appropriate initial management that you have to give in this patient? Immediate electrical cardioversion, IV beta blockers, initiate anticoagulation, perform EP study. Very good, Supra Kumari. So you need to start the IV beta blockers, right? Because I did not mention in the question that the individual is hemodynamically unstable. Okay. So if nothing is being mentioned, what is it you need to consider it as? You need to consider that the patient is a stable AF patient. And in stable AF, the initial management, it should focus on the rate control. And how is that you will achieve the rate control? That is by the beta blockers, right? But if the duration, if it is specifically mentioned that if the duration of the atrial fibrillation is like more than 48 hours, then cardioversion should be delayed until anticoagulation is established, right? If the duration is more than 48 hours, the cardioversion should be delayed until the anticoagulation is being established. Okay, so that is about the first question, right? Second one, very simple one. Which scoring system is used to assess the stroke risk in AF patients and guide the anticoagulation decision? Yeah. So this is your CHA2 DS2 VAS scoring system, right? What about this Hesbled score? Hesbled score will tell you what is the chance of bleeding once you start this anticoagulation in patients with atrial fibrillation. That is what is your Hesbled score, right? Next, third. 60-year-old female with CHA2 DS2 VAS of 3 is started on oral anticoagulation. Which anticoagulant has been shown to have lower risk of intracranial hemorrhage when compared to that of the warfarin? When compared to that of the warfarin. Very good. That is the Epixaban. And what is the name of the trial? Can anyone tell me what is the name of the trial? Where there was comparison of the warfarin with Epixaban. Just now we have discussed all the trials. What is the name of the trial? So the name of the trial is Aristotle trial. Okay, so now, yeah, very good, Dr. Dipal. So now you need to remember the trials. Trials are very, very important for the examiner to ask the questions. Next. Okay, so in which clinical scenario catheter ablation preferred over the medical therapy for the atrial fibrillation? Go through all the scenarios. Catheter ablation preferred over the medical therapy for atrial fibrillation. Right, good. So in case of paroxysmal atrial fibrillation, catheter ablation is being preferred, mainly if the individual is refractory to the antiarrhythmic drugs, right? Refractory to the antiarrhythmic drugs. And the point here is this catheter ablation, right? The catheter ablation, it is not the first line, right? It is not the first line in permanent AF, right? It is not the first line in permanent AF or AF due to structural heart disease. Right? AF due to structural heart disease. So we don't do catheter ablation in these scenarios, right? Next question. But in paroxysmal AF refractory to medical management, catheter ablation should be done. Next. A 68-year-old man with heart failure and AF started on rate control therapy. Which medication is contraindicated in this patient? Which medication is contraindicated in this patient? Anyone? So, bisoprolol, digoxin, verapamil, then amiodarone. Not digoxin, not amiodarone. So the patient is in state of heart failure. When the patient is in state of heart failure, do we give calcium channel blockers? We don't give calcium channel blockers, right? So non-dihydropyridine calcium channel blockers should be avoided in heart failure, particularly in patients with HFrEF. Right? Particularly in patients with HFrEF. Why? Because of negative inotropic effect, right? Whereas the beta blockers and as well as digoxin, they are the safer options, right? So it is not bisoprolol, it is not digoxin, it is not amiodarone. So it is your verapamil that has been contraindicated. All right. Next question. Okay. So a patient with atrial fibrillation has been stable on warfarin for 2 years. Has been stable on warfarin for 2 years. His recent R is 3.8. What is the next step? Yes, what is that you will do if the INR is like 3.8 and the individual is on warfarin? Very good, Alina. So you need to hold warfarin for nearly around 1 to 2 days, then resume at a lower dose. So how much should be your target INR? The target INR should be around 2 to 3. And if the INR, if it is more than 3.5, that increases the bleeding risk. Right, that increases the bleeding risk. So dose adjustment is very much required. Dose adjustment is very much required. Okay, so this is about when the INR is 3.8, what is that you need to do? A patient with atrial fibrillation has been taking warfarin but is switching to dabigatran. When should dabigatran be started? Immediately after INR below 2, after INR falls below 3.5, overlapping for 5 days with both medication. Yes. Overlapping for 5 days with both medication? No. Because you don't require to overlap for 5 days. Because dabigatran, it does not require the onset of action for 5 days. It is not like your warfarin. It is not D. Dabigatran, it has an immediate onset of action. You don't require to overlap at all. When do you require overlap? If you think that dabigatran will take 5 days for the onset of its action, then overlapping is required. And dabigatran does not require 5 days for the onset of its action. So what is that you need to do is, whenever you're switching warfarin to dabigatran, first stop the warfarin, right? So warfarin has to be stopped, right? Once the warfarin is stopped, then the direct oral anticoagulant should be started. But when is that you should start? Direct oral anticoagulant should be started once INR is below 2. Once INR is below 2, then you need to start the direct oral anticoagulant. Why? Mainly to prevent the excessive anticoagulation. So mainly to prevent the excessive anticoagulation, you need to start after the INR falls below 2. Okay, so that is about when to start dabigatran after stopping warfarin. Okay, this is a question about the trials. Which major clinical trial demonstrated that early rhythm control in AF reduces the cardiovascular event compared to the rate control alone? No, it is not affirm trial. Affirm trial said like rate control is like more important than compared to that of rhythm control. But which particular trial said rhythm control should be started early? That means early rhythm control means within 1 year of the atrial fibrillation diagnosis. Right, within 1 year of the atrial fibrillation diagnosis. So East AFNET 4 trial said it showed that the early rhythm control reduces the cardiovascular risk, it reduces the stroke, reduces the heart failure hospitalization compared to the usual care. That is about the East AFNET 4 trial. Then next question. Which of the following is a key finding from the ROCKET AF trial comparing rivaroxaban to the warfarin? Warfarin was superior. Rivaroxaban has a higher risk of major bleeding. Rivaroxaban was non-inferior to warfarin. Rivaroxaban had no effect on stroke prevention. Right. So, right. Very good, Dr. Deepal. So the answer is rivaroxaban was non-inferior to warfarin for stroke prevention. That is what is the answer. Okay. That is according to ROCKET AF trial. Next, last question. So please remember, I've said you about 6 trials in the theory part. All the 6 trials are very, very important. There is a high scope for asking multiple choice questions on the trials. Okay. Next, a 55-year-old man with atrial fibrillation and Chart2-DS2 VAS scoring of 1 asks if he needs anticoagulation, what is the best recommendation? No anticoagulation needed. Start warfarin, start aspirin, start rivaroxaban. Yes. Anyone? So remember, when the score is 1 in case of males, they don't require the anticoagulation. They don't require, yes, definitely you need to start aspirin. But the question is about, he is asking whether if he needs anticoagulation. That is what is the question about. So you need to answer whether the anticoagulation is required or not required. No. What did I tell you? In case of males, when the score is more than or equal to 2, you need to start the anticoagulation. Whereas in females, what did I tell you? The Chart2-DS2 scoring system, if it is more than or equal to 3, then you need to start the anticoagulation. Okay. So this is about the questions related to the atrial fibrillation. So basically, this section mainly have concentrated on the topic of the atrial fibrillation, right? I should have taught even VT and as well as VF, but I thought like it would be more voluminous in one particular section. So in the subsequent sections, I will also discuss the VT and as well as the VF, right? But please remember, in the cardiology mainly, you need to concentrate on the trials. There is a very, very high scope that they will be asking you the questions on the trials, okay? So thank you very much. This is for today. And the next session is on, we don't have tomorrow because tomorrow is a holiday, that is the Holi. So next session will be on 17th at 6 p.m. Right? So until then, goodbye. Thank you very much.